Hello, everyone. Thank you for joining us on this COVID-19 diabetes webinar. I'm Dr. Mayank Patel, and together my good friend and colleague, Professor Partha Kar, we'll be talking about acute aspects of management of COVID-19 from a diabetes perspective. We recognise that a number of you are working in extended roles in a challenging time where access to diabetes support may be limited or lacking. As part of our role, Partha and I were part of the National COVID Response Group, which has produced several sets of guidelines to help healthcare professionals, both specialist and non-specialist, manage the care of patients with COVID and diabetes. So this evening on this webinar, we're just going to walk through our first guideline, which was about treating people with diabetes at the front door. So without further ado, I will start to walk through some of the guidance we've put together. Next slide, please. So what's really important is that when a patient presents to the front door of a hospital who's unwell in the current climate, it's ensuring we don't miss a diagnosis of COVID-19 naturally, but it's also recognizing there are other causes of distressing symptoms to patients. So in particular, as highlighted here, it's important when assessing a patient, recognizing shortness of breath may also be caused by metabolic acidosis, such as diabetic ketoacidosis. So it's critical that all newly admitted patients are evaluated for diabetes. Hence, a glucose check is advised, as is a ketone check if glucose levels are elevated above 12 millimoles. For your patients with known diabetes taking medications, tablets, the SGLT2 inhibitors, or metformin tablets, it's recommended these tablets are suspended when patients are unwell and then reviewed in due course when patients start to improve. Next slide, please. When a patient presents with known diabetes, it's recognizing there's important action to consider if an individual has high or low glucose levels. It's likely if your patient has hypoglycemia, there'll be a local protocol in place to manage this. If your patient has a blood glucose above 12, other urgent considerations should be thought about. Chiefly, it's ensuring you consider your patients not experiencing diabetic ketoacidosis or hyperglycemic hyperosmolar state, otherwise known as HHS, and it's likely your hospital should have protocols for both of these conditions. In addition to which, recognize if your patient has type 1 diabetes, they'll be on lifelong insulin, and hence any individuals taking long-acting insulin should have this continued and never suspended, even if your patient goes on to an insulin infusion. It's also worth remembering individuals can have high glucose for different reasons beyond COVID, so ensuring you don't miss a new presentation of diabetes, for example, type 1 or type 2, and recognizing other sources of infections, such as foot disease, for example. It's ensuring individuals who use insulin pumps or other technology, there are no malfunctions causing high glucose, and also recognizing a high glucose level may be the norm for this patient, which reflects that their usual diabetes treatment is perhaps not quite where it needs to be. It's also recognizing the impact of steroid-based therapy, tablets and injections particularly, that can cause high sugar levels. Next slide, please. In the context of COVID and diabetes, an increasing number of patients have been found to have high blood ketone levels, which can be a marker of increased risk of developing diabetic ketoacidosis. Most hospitals are now equipped to check an individual patient's blood ketone levels, and levels above 1.5 to 2.9 suggest an increased risk of diabetic ketoacidosis, and there may be a need to increase fluids for your patient, and recognizing the potential need for using rapid-acting insulin injections intermittently to lower glucose levels carefully and align with your local protocols that should be in place. A blood ketone level above 3 would suggest a high chance this individual is on the cusp or has developed diabetic ketoacidosis and hence should be managed as per your local protocol. The additional comment I would make is that in individuals who use the SGLT2 inhibitor tablets, the flozin tablets such as canagliflozin, empagliflozin or dapagliflozin may also experience diabetic ketoacidosis with a relatively normal blood glucose level. So be on the lookout for that as a particular feature with COVID infection. Next slide, please. In addition to which, it's making sure, as touched on earlier, if a patient has type 1 diabetes or is on long-acting insulin anyway for type 2 diabetes, this should be continued throughout their whole hospital stay, ideally. And even if your patient requires the use of a variable rate insulin infusion, there should still be a need to continue the injected long-acting insulin. Sometimes if individuals can't be managed with insulin through an insulin pump, an infusion device, there's an option to use different protocols with injected subcutaneous insulin, and your hospital should hopefully have a protocol in place. An increasing number of patients are also using wearable technology. Partha, any thoughts on that?
So I think, first of all, I'll start by saying, just echo what you started your talk with, which is thanking a lot of our colleagues across the NHS for the work they've been doing in these very, very difficult times. And at this piece of work, which Mayank, you yourself have been a fundamental part of, and a huge thank you to Diabetes UK for helping to sort of coordinate the process. And I think if you go through everything that you mentioned, I think what we do have in this particular, you mentioned about the diabetes wearable technology, which is a big step change compared to where we were, let's say, 2-3 years ago. We have got a significant number of population now on different types of technology, which isn't your traditional way of checking blood glucose, whether it be, your Freestyle Libre, whether it be Dexcom in short. It's a fundamental change of how we check people's glucose levels, and they're wearing it on their person, so to speak. And thereby, it needs awareness for all teams to be, so when they look at this device, they're not surprised or taken on the back foot as to, what is this device? Awareness of that is part of, I would say, progression of diabetes technology. So I think what we do have is a series of guidelines and informations and tips, to put it very simply, a way of trying to help people, help our colleagues in very, very busy lives with improving care of people with diabetes when they're admitted to hospital.
And Partha, why is it that the technology is perhaps less reliable in hospital inpatient care than checking glucose levels, for example?
I think there are many, many sort of theories behind it. I think one of the things is about, there's a lot of jury out on this, because at one point of time, lots of hospitals would say there should be used technology inside the hospital, should be not. There are about, as the devices are improving, how good is it at the extreme edges, especially at low readings, so to speak. So there's been lots of devices and lots of debate as to where these wearable technology fits, if that makes sense. But at the same time, we are having growing data coming through, better technology coming through, I would also say. You got the Libre 2, you got the Dexcom moving on to, hopefully in the future, the G6 and G7. I think they'll be better and more amenable to using in, inpatient settings, in acute settings of fluctuations of people's well-being. So hopefully this will become par for the course, I would have thought, in due course.
Are there concerns that these devices, because they measure skin fluid glucose, Partha, rather than blood glucose, might be less accurate for that reason in a dehydrated patient, for example?
I think that's exactly one of the sort of arguments given. I mean, there are two schools of thought on it. One is, are we looking for, so as you said, one school of thought would say it's not accurate with the level of dehydration in play, the sepsis at the background, is it picking up accurate enough readings? The other school of thought would be that, are we looking for a perfection of levels, or are we trying to get a ballpark figure so we know where people are, rather than trying to get exact accurate numbers? So I think there are different schools of thought on it. And during this period of time of the heightened crisis of the first wave, some of you as listeners might recall that, Abbott themselves had provided some support to some centers by giving Freestyle Libre out to see how it was used in people who were admitted. So I think different schools of thought on it. More data is coming through in this particular area, so it'll be interesting to see how it evolves.
Okay, so I guess to close this bit, if some patients like to keep using their technology, I think clinically, if there's any concern the data is unreliable, it should always be counter-checked with a blood glucose level to make sure.
Yeah, and I think that's always the case, whether they're inpatient, outpatient, as you very well know, and we always talk about this, and this is what we say to people, if it doesn't sort of fit the clinical picture and you're not sure about the accuracy of what you're seeing in front of you, double check it. And we would do that, for example, we do that with sodium levels or calcium levels or any of that, and it's no different at this particular instance as well.
Thank you. And to close this off, and as these devices contain metal, obviously, it's important they're removed before any kind of scans, such as MRIs, as outlined here. Next slide, please. And this summary slide just illustrates the fact that our guidance has been put together as a group is a sort of fluid document whereby we've evolved and tweaked changes, made changes over the last few months, depending on the national feedback we've received from individuals managing patients with COVID. So, for example, we've changed guidance subtly in terms of recommendations around suspending or stopping metformin, the SGLT2 inhibitors, tablets, etc. So being mindful that the situation can change from time to time. It's also recognising with hydration of patients, we must be very mindful not to flood patients too aggressively because of risk of causing lung leak, etc. So be mindful about how carefully we fill patients' fluids, and fluid balance is a critical part of that. It was apparent during the height of the pandemic that some centres ran out of insulin infusion pumps and had to use subcutaneous insulin injection regimens. So that may be something your centre is experiencing or using. So do look out for that. But also recognise that some individuals require a lot of insulin when they're very sick. So if someone requires more than 10 to 20 units an hour of insulin, whilst that sounds quite daunting, it may just reflect the natural aggressiveness of the disease, sadly, causing rampant hyperglycemia. So don't be too concerned as long as appropriate monitoring and guidance is in place. Next slide, please. So we had a couple of questions through based on the acute presentation of patients. So Partha, I can ask you, if someone wrote in and asked what if my hospital's got no diabetes service, what are your thoughts from that from a national point of view?
So I think what we have made quite clear, I mean, I think it's important to sort of reflect that when you talk about diabetes service, we are not talking about outpatient services, because that has been a sort of continuous thought that, oh, diabetes means it's an outpatient specialty. No longer is that true in present times. Every hospital must have an inpatient diabetes team, which is to help other teams with their diabetes care. So I think if you're individually worried about, do I have a diabetes team, you should absolutely make sure you contact the local diabetes team to find out about their inpatient cohort. Now, we do know from the national audit, there are some hospitals which still supposedly don't have their inpatient diabetes teams. And we are very clear from a national perspective that that is no longer a position to be held, whether it's from the GIRFT report, whether it's from all the national audit report. It's very, very clear that one of the fundamentals is that your hospital will have a diabetes inpatient team. That's a fundamental part of being a diabetes team. So I would say that if they don't have a diabetes service, it's something that needs to be flagged higher up, because that wouldn't be purely on safety grounds, if not anything else, an acceptable position to hold.
Absolutely. We've talked about the fact that the COVID pandemic has shone a light on diabetes in terms of the heightened risk of morbidity and mortality that the disease has sadly brought individuals with diabetes. So there is high anxiety, I'm sure, part of our patients locally, and I'm sure yours as well. So I do value your thoughts for the central view on that. Thank you. Next slide, please. Yeah, somebody queried, Partha, asking about this is all well and good, but what if what we're doing is fine? Why should I follow this?
Yeah, so I think with these things, I always say it's got guidance, has got the word guide in it. It's supposed to help you. It's not sort of set in stone. The basic philosophy of these guidelines is to help colleagues across the country. If you've got local guidelines to look after people with diabetes, fantastic, follow them. If you're happy with it, fantastic, follow them. The guidelines that you refer to are just that. It's to help people who may not be in a position. And what we don't want to do in these busy times are people to scramble and create their own guideline. If you've got one, use it. If you don't have one, use the one that we are sort of suggesting. It's nationally agreed, and it's been done by a group of experts. It's been supported by patient organizations. So I would say just an added tool to your weaponry, so to speak. So do you have to follow it? Nothing is mandatory, but do have something to follow is the advice, I would say.
Thank you. I mean, I guess building on what you said earlier about the GIRFT and national view, there are some centres who are very well resourced and others that aren't. So we feel that by offering this as a minimum level of support, we don't feel we're treading on toes. If institutions have other things in place, then that's all well and good. Thank you. Next slide, please. And our last question came through. Yeah, Partha, what do you think of this? Should I allow my patients to self-manage their diabetes if they've got COVID in hospital?
I think the answer is, it's multi-layered, but at the end of the day, it's the whole term about allowing anybody to do what they want or not is not really up to healthcare professionals to decide. I think the bottom line is if the patient is compos mentis or within their senses or has got carers who can look after them and knows what they're doing with the diabetes, please let them do it, because they probably know more about their diabetes control and care, what needs to be done than most other people around us. On the other hand, of course, if you've got a patient who's sick and not, within their compos mentis, or, you're worried about their level of consciousness, of course, you follow the protocols to help them manage their diabetes. But once they are in a position to self-manage, they should absolutely be self-managing. I don't think it's a question of allowing. I think that should be the default position, if I'm honest. And that's why, again, the national position is that have self-management pathways, protocols, and that should be the standard position. Yeah.
So we should respect autonomy from what you're saying, Partha. And obviously, if an individual is incapacitated or there's no others with them, then we can step in and work with the patient, not do everything for them necessarily, but try and work with the patient and explain to them why there's a need for somebody else to step in, perhaps when the person's not used to it, I guess, Partha, something like
100%,
that.
100%. Couldn't agree with them more. 100%.
Okay. Thank you. So that ends our short webinar on the acute presentation of individuals hospital with COVID-19. We hope you find it useful. And once again, thank you for all you're doing and stay safe and stay well. Thank you.
Thank you very much.